Pulmonary hypertension is a lifelong condition that's treated orally where patients suffer from high pulmonary blood pressure. After testing for 8 ETA receptor antagonists, I recommend to bring compound LN215 into the clinical phase since it consistently shows optimum pharmacokinetics, which you shall see in this video. As demonstrated by Chester et al., in pulmonary hypertension, ET1 produced by endothelial cells binds to ETA receptors on smooth muscle cells to stimulate vasoconstriction. ETA receptor antagonists work by blocking the ETA receptor, reducing stimulation of vasoconstriction. In this video, I'll go through each set of PK data here sequentially to explain which compound to bring forward or leave behind. Then at the end of this video, I will summarize why we selected LN215 for the clinical trial and suggest further tests for the compound. Let's start with absolute bioavailability, which is calculated by the following formula. This refers to the amount of oral drug which reaches the systemic circulation. Compounds LN142 and 215 have the highest absolute bioavailabilities at 83.3 and 75% respectively. In contrast, LN208 and LN221 have very low percentage F at 10%. They are not brought forward due to minimal systemic circulation and inadequate receptor blockade. Current ETA receptor antagonists typically exhibit from 49.8 to 90% bioavailability. Enhanced bioavailability allows for reduced dosage recommendations, improving drug cost effectiveness to manufacture, and affordability for healthcare systems with constrained budgets like the NHS. It may be easier for patients to adhere if they do not have to take a high dosage every time. For absorption rate, it can be calculated by this formula. This is the rate at which the drug can be absorbed into the bloodstream. As we can see here, compounds LN127 and LN215 have the highest absorption rates at 20 kA per hour and 16.7 kA per hour respectively. Compound LN232 has very low absorption rate and hence they would be undesirable as drugs for patient treatment. This is because more time is given for intestinal decomposition and metabolism, lowering the yield of therapeutic compound. It also takes longer to display therapeutic effects with a low absorption rate. There's also a higher chance that it will just be cleared from the body via the intestinal route. These compounds tend to bind to plasma proteins after absorption into the bloodstream, influencing their distribution. We can see LN127 has the highest percentage unbound to plasma proteins, which means that a high proportion is ready to diffuse into tissues. Although LN215 and 015 have low percentage unbound to plasma proteins, they have the highest dissociation rates, being 10,000 times higher than that of LN142 and 209, so they can become unbound really easily and enter tissues. In contrast, LN142 and LN209 have both a low plasma unbound percentage and low dissociation constant, so they can hardly enter tissues and are left behind. Then we move on to volume of distribution. This indicates how widely a compound is distributed throughout the body. LN127 has a very high volume of distribution at 10 liters per kilogram, and LN215 has a moderate volume of distribution at 5 liters per kilogram. They allow compounds to distribute more in tissues instead of plasma, reaching the target ETA receptors. LN015 has a volume distribution below 1, hence it's eliminated as only a very small volume of drug would reach the tissues. In terms of safety and tolerability, a volume of distribution that's too high increases the chance of off-target binding. Hence, a moderate volume of distribution can have more specific binding to ETA receptors. However, there's no clear threshold into which the VD is too high for ETA receptor antagonists in literature. Hence, only LN015 is eliminated. Lastly, the half-life and clearance is discussed. To target pulmonary hypertension requires a lifelong treatment. A prolonged half-life and low clearance for drug is preferred so that we can have sustained effects in blocking the ETA receptors. LN215 has 2 times higher the half-life of LN127 here, at 9 hours. Current ETA antagonist half-life ranges from 5 to 19 hours from literature. This shows that LN215 fits into the status quo of current endothelin antagonist half-life and is not too long in comparison. However, half-life does not give a full picture of how long the therapeutic effects can last. This is because of factors like enterohepatic recycling, where the drug is excreted in bile and then reabsorbed from the intestines, prolonging retention in the body, hence therapeutic effects. And highly lipophilic drugs can have significant tissue binding and later redistribution from tissue to blood, prolonging drug effects. Therefore, we also looked at clearance, which indicates the extraction of drug from the bloodstream and eliminated. LN215 has 5 times less clearance rate, hence would have much more sustained therapeutic effects. When comparing LN127 and 215, in terms of safety and tolerability, moderate volumes of distribution means a lower chance of off-target effects as mentioned, having a less chance of inducing ETA blockage in other areas of the body and causing side effects, such as large-scale vasodilation. In terms of efficiency of the drug, LN215 has moderate to high levels of absorption rate and volumes of distribution, while having 1.5 times higher absolute bioavailability, 2 times the half-life, and 5 times lower clearance, giving it an overall advantage. So we've come to a conclusion to select LN215 to enter our clinical phase trials. This is because it has high absolute bioavailability, which means that it's going to be cost effective. It has moderate to high absorption rate, which means that I can have rapid therapeutic effects. It has high dissociation rate to counteract the highly percentage bound to plasma proteins. They have moderate volumes of distribution so that they can reach the ETA receptors on smooth muscles efficiently. And they have long half-life and a low clearance for sustained effects for the ETA receptor antagonists to treat the chronic pulmonary hypertension. Here are some suggestions for further testing. Firstly, we should test for a co-administration of the drug with common recreational drugs, as drug-drug interactions can affect pharmacokinetics, particularly the metabolism of a drug. For example, in a paper by Volton et al., bosentan induces CYP3A4, which metabolizes several contraceptives, potentially leading to failure during co-administration, and should be avoided in patients with moderate to severe hepatic impairment. Hence, we should also test for the metabolism of LN215 upon co-administration with common recreational drugs, as well as drugs used to treat diseases commonly associated with pulmonary hypertension, such as hypoxemia, or left heart diseases to screen for potential harmful effects. Secondly, we should test for the selectivity for ETB receptors. This is because from literature, ETB can cause vasodilation when bound with ET1, which can alleviate pulmonary hypertension. Hence, we must ensure that LN215 does not block the binding of ET1 with endothelial ETB receptors, so that the vasorelaxant NO can be produced in endothelial cells to stimulate cGMP production in smooth muscle cells, hence causing vasorelaxation. Those are all suggestions for further testing, and here are the references. Thanks for watching.